Welcome to Living With. My name is Claire Wylds-Wright, and I have the absolute pleasure of being joined today by Dr. David Rye, who is a sleep specialist and professor of neurology at Emory University in Atlanta. Since 1992, he has worked there and built up a clinical practice and a research program for sleep disorders, in particular idiopathic hypersomnia and restless leg syndrome. Dr. Rye has received multiple awards for outstanding scientific achievements and is published in peer-reviewed journals, and perhaps best known for unraveling the mystery of idiopathic hypersomnia and, of course, paving the way to novel treatments that improve the lives of his patients. Welcome, Dr. Rye.
Well, I'm really glad to be able to pin you down after about sort of 9 months. I know you've been incredibly busy professionally and personally, but thank you, David Rye, for taking the time, because there's lots of updates. I know there's new things happening in the space and things that you're involved with, but just for the sake of our audience, I have this sort of mental image of you, like go back to the younger David Rye, like coming out of med school and deciding to go in sleep medicine. So I know that there's a lot written about you. I know you've written a lot. You're extremely prolific and successful, both as an expert clinician and researcher. But what went through your mind when you decided to specialize in idiopathic hypersomnia?
I think as someone who's a neurologist, you can't be not impressed when you're a resident and in a career doing general neurology in a hospital, how often the neurologist is called to the bedside for consults about people who, quite a few of those consults were for alterations in consciousness, right? And so you would see people who couldn't stay awake or weren't alert and aware, and they often had many other different disorders. And so I always thought, gosh, is there a magic pill, right, for these folks? And certainly some people with injury to certain parts of the brain that are more focal can certainly have some of that impairment as well. And I just thought that I got very interested in it because we would see it so commonly, but it was always a little bit of a different solution to some extent, because it was always in the setting of another organ of the body that wasn't functioning very well. Kidney, severe kidney disease or liver disease, or I think when you see somebody so profoundly affected by something that affects something so fundamental, which is consciousness, essentially, or conscious state, and then you can get them back, right? When I teach the residents or some of the students or residents, they say, neurology is really, you learn it piece of the brain or stroke by stroke, and what does a focal injury of some part of the brain do, or how does it negatively impact somebody? But I said, isn't it a little more interesting? Like, that's localization, structure, function, but isn't it really more fundamental to understand who's putting on the lights and who's turning off the lights? Because that other stuff follows, right?
Was that one of the first people? Was he one of the first people that you'd met with idiopathic hypersomnia then, David? Or
not in Chicago?
Like
we didn't really get interested, or I didn't. In the 90s, when I first got to Emory, I remember a few patients we had back in the old clinic building A at Emory, and back then the clinics buildings were much better stocked with pharmaceuticals and certainly under lock and key, but it was a much easier proposition to administer medicine to patient in a clinic. And in fact, there's many examples of that in neurology. I used to carry 3 or 4 vials of medicine in my the old fashioned leather doctor bag, because many times the diagnosis was the treatment, right? So we were continuing, at least for idiopathic hypersomnia, to push the same medicines people were using for narcolepsy. And we were certainly pretty, I think more at that time because modafinil, wasn't approved until right at the millennium, essentially, right? And then there was the discovery right at the millennium about the real root cause of type 1 narcolepsy.
Yep.
So that, I think, was kind of a seminal moment to kind of reconsider a lot of things. And at the time, I was the only editor. I was the only member of the editorial board of neurology that had any expertise in sleep. So I was reviewing 30 or so articles a year that were being, submitted to neurology, and got a lot more interested in the topic of type 1 narcolepsy, but also of idiopathic hypersomnia. And I guess what people were referring to at that time and before is, quote, narcolepsy's borderland, end quote, right? And that's kind of how it progressed. At the clinical side, I mean, my basic science interest, when I was in medical school in Chicago, was working on a part of the brain that generates dream sleep, kind of the last common pathway to dreaming. So, and I realized, at that time, I think there was only 1 or 2 sleep fellowships in the country or in the continent, or in the US, I think. And then at that time, you just kind of trained yourself, and there were certain, qualifications, and it was certainly an area of unmet need, sleep in general, and particularly brain-based issues related to.
What was it, do you think, during that time that sort of attracted patients with IH potentially to Emory and to see you as you were kind of emerging as a leading clinician in this space? Where were the shifts there? And when did they happen?
Well, the other person I was really critical at this time, because he came at the same time, was Donald Bleiweiss, who came from Stanford and had, that was really the mecca, and a lot of people had done advanced postgraduate training, both PhDs, and Don's a psychologist. And we were both recruited simultaneously to Emory. So much of this, I think we were partners in, early on, and he was very critical. And just his comments that the patient population we were seeing at Emory, if people are not familiar with it, it's in Atlanta, but it really kind of the largest, other than maybe Duke, prestigious in the Southeast, and the Southeast was booming. So I think when I first came, there were only 3 or 4 board certified sleep medicine, neurology based people in the state. So it wasn't much to attract folks. And Dr. Don Bleiweiss was saying, gosh, the stuff we are seeing is so different than conventional thought that I picked up at Stanford. I mean, one example was, and we wrote a paper on, or wrote a paper on, it actually got press released in neurology, was concerning the presentation of people with narcolepsy in their 40s, 50s, 60s, 70s, 80s, essentially. Like, why is this, right? And it sort of fueled a little bit about, well, we need to really communicate some of this, because this is very important to, to the understanding of the disease, and also particularly to treating it, right? Right. So, and there were a lot of things yet left to do, right? Why do these drugs work?
Right.
I mean, I remember nobody knew why stimulants, traditional conventional psychostimulants, helped with wakefulness, because nobody appreciated that dopamine was a major neurotransmitter for wakefulness. You know, it was always implicated too much, and you have psychosis, too little, and you have Parkinson's disease, but nobody really sort of looked at, it wasn't really known well, the mechanism of action of amphetamines, and everybody thought, well, this is just an adrenal and noradrenaline thing. So it took just that shift in and of itself to the idea that dopamine has a function for wakefulness as well as sleep that was never fit.
You must have seen a lot of patients with narcolepsy type 1 and type 2. And I just wondered whether, you've got any comments now, currently what the scene looks like in that differentiation between NT2 and IH, because it's so confusing, isn't it, for people seeking a diagnosis, for like the general public to understand the difference, and even at research level, it's a bit of a mess, isn't it? What would your current views on that differentiation between NT2 and IH, idiopathic hypersomnia?
Differentiation between NT2 and idiopathic hypersomnia. My current view, based on data, experience, I think one of the meetings we've had not so long ago, in the last 4 or 5 years, I think Gert Lammer said it well, is that NT2 is a side effect of getting an MSLT, right? So this issue that REM sleep or dream sleep is so plastic and just may or may not show up based on all kinds of factors. Maybe it works in your favor or not. You have 2 of these naps with dreaming, and then you can be labeled narcoleptic according to criteria, but is it really that? Because so many of these people sleep long, have a hard time waking up. Their naps are long. They have some other clinical features that sound much more like we hear in idiopathic hypersomnia. And then you retest some of them, as now several groups have done. I think we were the first to publish. And that multiple sleep latency test is just not consistent in these folks. So we have this little snapshot of a day that somebody's dragged out of the real world and put into an unusual environment.
Lab.
And, then that label stays with them or sticks with them or not. And I've had dreams when I come home and take a nap, sometimes in the late afternoon. Does that mean I have narcolepsy? So it's...
Probably not.
One of the old, in terms of my thinking, I think it'd really be nice to get back to the idea that dreaming is one of the more heritable parts of sleep, and that when there were a lot of basic scientists from a psychiatric background as well as clinicians, dreaming, the propensity to dream, how much you dream, when it occurs, the frequency, the duration, and how much phasic activity, meaning eye movements and other things that are recorded in it, was really a marker of affective illness. And I think, meaning dysthymia, depression, bipolar disease. And really, there's not that whole group of folks we're moved on to a new generation. There's not too many that really remember that, other than folks in my generation, maybe. So I always think a little bit about affective components in patients that aren't type 1, that look more like.
Okay.
And there's many. I've seen it in families, multiple members, 2 to 3 members in families, and as parents, I think the listeners or yourself can relate to. I mean, what would you rather hear from the doctor, that your offspring has narcolepsy with 8 or 9 approved medicines, or that they have bipolar disease? A lot of approved medicines, but a much more stigma to that, I think, even.
Mm-hmm.
And so they'll gravitate, and we spend a lot of time in clinic educating parents and patients about the nomenclature.
Mm-hmm.
A lot of time, because they're very confused.
Is that still a challenge then in the clinic setting? Because I kind of always think of you as being this sort of, you're at Emory, you've got, institutional history, you've got research history, you've gone through decades of being kind of established in the IH community, and patients, you're the go-to, right? You're the number one for IH. Well, I think my question is how far do you think that the kind of scene for diagnosing sort of efficiency has sort of happened over the last like 1 to 2 decades? Because our hope is that people, the awareness is raised and that people understand the condition more, but also the differentiation between that and narcolepsy, and that people with IH aren't always seen as like the poor cousins, always sort of shortchanged. So,
well,
I do appreciate what you said about narcolepsy, but I never really sat there with bipolar disorder as a caregiver. But certainly IH is very complicated.
Well, mental health diagnosis in terms of insurance coverages and the stigma and the chronicity. Not that these other disorders are not chronic, but and so I think. First of all, two comments. One, I think there's progress, right? We see more people coming with more thoughtful workups.
Right.
And maybe an extended sleep at night, maybe actigraphy. I mean, most of this we see from people at other academic centers at some level. And I've said this before, and I think it would be great if you have someone wants to write or help write or whatever. I think a paper, a manuscript, we call it a white paper, whatever. Why does it matter? I mean, if you have a certain cancer, you have lung cancer type A or type B, treatment's going to be different, right? The molecular biology is different. I mean, are we at that level of knowledge for this differentiation as it regards people that have somnolence? And the answer is no, but we have some, right? And I think, what are your questions you're going to ask? Well, does the diagnosis affect which treatment I get? What's the heritability, of these disorders, right? You want to know, could this affect my children? I mean, these are questions you would ask for any other disorder, I think, going to a physician. And then you'd ask, what's the prognosis? Is it going to get worse over time, or is it going to get better over time? And there's not perfect data, but I think it's still worthwhile maybe putting down a stone and saying, this is what we know right now, and why why do we care about this so much, this difference in nomenclature, right? And I just think it's long overdue.
So do you think that is a valid question, that there is a chance that people with idiopathic hypersomnia do improve over time? Because I think certainly sort of in the open forums on social media, there's such a wide it's very speculative, but people obviously do want to cling to hope. What are your views on whether IH is a disorder that improves or not?
Well, we've seen people, right? I mean, we've been at the same location for 30 years, and I still see people who were either lost to follow-up, and then because we essentially consent everybody for research that, recontact that walks through the door, and we really haven't had, I can count on one hand, people that have said no. So when when we have seen them and done spinal tap, lumbar puncture, and a lot, and then we're writing a paper or talking about something. Oh, whatever happened to so and so? Because these people we have institutional memory for, right? I mean, we've had a lot of the same staff and support staff, and so we know it gets better in a group of people, or goes away, in fact. And then there's another group of people that continue to see us because they're just interested, and are much improved. We see all, and then we see people that are it's a more chronic, situation. So, but I think that's important, right, to put out there, right? I mean, several of those people from the 90s I still see. I mean, I've got 25-year follow-up. I mean, any kind of a longitudinal assessment or study are always difficult for lots of reasons, including the investigators moving. Loyalty, that was the other one. Sidney Poitier, perseverance, loyalty, character.
You got it. All of those things. I think that's definitely why I think Dr. I people so very much trust you over such a long period of time. I wanted to ask whether you feel people with IH should be optimistic about treatments that may or may not be forthcoming. What does the sort of treatment scene look like for people with IH over the next 2 to 5 years, in your opinion?
Well, I think it's, there's a lot of activity, right? I mean, narcolepsy was what people cut their teeth on, type 1 narcolepsy, and still how we learn sleep medicine from a brain perspective. And we know a lot now from that. And now we're kind of, I think, in the last frontiers, right, to some extent, is somnolence in general, hypersomnolence, hypersomnia in general, outside of that well-definable type 1 narcolepsy, is now like the holy grail, right? I mean, Don Blywise actually wrote a paper commentary years ago. I think it's in one of the pulmonary journals, about, is sleepiness the holy grail of sleep medicine? I think now people are, collectively focusing on a lot of this, right, from different aspects, biomarkers to explain or differentiate cause, diagnosis, cause, and treatment. Still challenging, I think, because there's so many confounds that have to be considered. It kind of goes back to my initial comment about how many times we were consulted to see people that had an impaired consciousness in the hospital. And ferreting out the different subtypes, I imagine we would call them, subtypes with dysautonomic, autonomic nervous system symptoms, others without, those with depression, either current or past or yet to come.
Right.
I don't know.
Right.
With hypersomnia, is that a subgroup? So that's, to me, a big challenge right now. I mean, it's gotten me more, our work focusing more on drug response, I think, is being something to pay more attention to. Why not, right? It's probably as good a phenotype as anything else we got, and it's pretty unambiguous in most instances, especially if somebody stays on the medicine and pays for it.
Yeah. Where would you like to see research in idiopathic hypersomnia go in the next sort of 10 to 15 years? What direction do you think it needs to really address?
And earlier recognition, I think. We see a lot of folks, because many of the symptoms begin in teen years, right? And that's really it's terrible time, right? I mean, think of all the disorders that really kind of narcolepsy, type 1, type 2, atypical depression, schizophrenia, bipolar, and idiopathic hypersomnia all start in the, or can start, or most prevalent in that time frame. So it becomes critical, I think, to have diagnosed, to understand them all, so we can get a quick diagnosis between those, because treatments are quite different between all those four disorders, and certainly the stigma and how it affects, and we've seen it. I've seen people come over because of this artificial 21 years old distinction between pediatrics and adult, and they're just not, they don't have the right diagnosis, even from esteemed places. I think I've presented several of those some talks, but I don't know if people really empathize maybe so much with this. But as a father of 3 and now a grandfather of 4, I couldn't imagine. I just can't imagine the frustration with floating around for 5 or 6 or 7 years of a formative part of your life. That's going to say so much of who you are and who you're going to become, with a bunch of ersatz academics and physicians. I mean, it's just that with wrong treatments and inappropriate, that really affect people. I mean, they're
and especially with pediatrics, where they haven't had their childhood, or these kids can't advocate for themselves. Even teenagers, it's so confusing, it's so overwhelming. So to get to a quick diagnosis,
and I get a little worried. I mean, that limbic portion of us, right? That limbic valence is so critical for clinical judgment, right? And we see so many people, and I mean, we could put those together in a book where we've got medical records of people that were taken to emergency rooms because they had slept for 20 hours. And the discharge summary saying that they were malingering. And the physicians basically, just
write them off.
Them off. And you're like, I actually used to hand out a paper. There was a study years ago that was published, and I used to keep too many papers around, stacks and stacks and stacks. But one of the ones I would hand out to the new residents every year was one that came out of the Queen's Square in London. And it was a retrospective study looking at a diagnosis of hysteria, call it what you want, faking it, malingering, Munchausen's, hysteria. And like 15 years retrospective look back at those charts, and half of the time there was a real diagnosis that eventually emerged in that person that explained why they had, they could easily explain why they came in with that particular complaint before. So when my point to the docs is, when you cast somebody off based on that, you got about a flip a coin chance that you're wrong.
I think that's very much a lived experience for probably most of our audience. Really.
Doctors aren't well known most anymore for humility.
You might be the exception to the rule.
I tell patients all the time, and the more I learn, and that's why I get nervous about talking to smart people like you, is that the more I learn, the less I know.
That's a sign of wisdom, I think.
Restless Legs, another one, right? I mean, we found genes. I've seen 4,000 or 5,000 people. I understand it pretty darn well, but boy, there's more interesting questions now than at the beginning of that road. And I think for me, that's the case with hypersomnia. I also think there may be some other disorders where we may get insights, right? If we can find things that have a what's called a phenocopy, right? Something that looks very similar. Well, that was our interest in myotonic dystrophy, and still a little bit is. People with liver failure, there's Cochrane reviews. Clomazonil works really well in those folks. Nobody ever followed up with it in terms of a mechanism of a way of delivery in that patient population. And I've seen people with liver failure a lot on the neurology consult service. And if there's one thing that their family says they start doing is sleeping more when their livers start getting worse, because they tend to wax and wane. So another disorder.
What's yeah, I mean, we could talk more about restless leg, because I know that's even the email that you go by is
well, there's
quite
a story
confusing,
behind. There's a story behind.
Okay, what is that? What is that
Well,
story?
when we
Because I
were-
always
well-
like type in
No.
when I go to email you, I type in David, and I'm like, no, it's restless leg. He's the restless leg guy. So it's quite interesting.
Years ago, back when we were doing genetics in Iceland on restless legs, and I was visiting with my dear friend Alan Levy, who's just stepped down his chair and focusing his efforts here at Emory on cognitive Alzheimer's disease and cognitive issues, which we're actually helping with a little bit. We can come back to that. And actually, I remember interviewing him when he was a medical student for residency, Jim Law, who's now still at Emory working in the same field. We were there visiting, and we were trying to get access to Emory email, and we were just getting shut out because we're another country, Iceland, I don't know, at decode. So I had to create a Gmail account. And Jim said, I said, well, I'm not good at emails. And Jim says, well, how about RLS Rye? I said, fine, right? So that goes back to like 06.
Wow. And you still have it? Because that's not, I've learned from like fishing around in my inbox, like, yeah, okay, it's RLS.
So that's where that came from. And actually getting back to it, I think technology also is going to be big. So we're working with a company now, and I know Dr. Mignot is a little bit, NextSense, who's based out in California, who's developing earbud technology to record sleep wirelessly. So looks very promising. And so then we won't be getting snapshots. I mean, in lab right now, we've published abstracts that show the technology is almost as good for recording brainwaves. So next step will be, soon, right, is to get it out into the real world and see if we can get a broader picture of time, right, a panorama view of a patient with hypersomnolence, right, or hypersomnia, not just these snapshot views in a sterile, unfamiliar environment, right? So that came through this institute Dr. Levy has started, because they want to do their motivation was to be able to study people with cognitive impairment that were older in their home environments as a way of partial monitoring.
Yeah. So that's instead of patients going to a sleep lab to have a sleep study, you're saying that the technology is evolving so that they can have just wear AirPods or headphones, something like that, that would do a really accurate kind of simulation of.
I mean, it beats actigraphy. I mean, actigraphy I don't even really do anymore, because unless it's like 5 standard deviations from norm, and we don't see too many of those, but not typically very good at picking up naps.
So last question, I think that is really optimistic, and people will be so glad to hear that at least sleep studies are going to change radically.
Well, I think the one thing you could do for that as a group is we need a push, because somebody asked me this, what one thing could we do? I said, well, don't make people wake up at 6 in a sleep lab. Let them sleep till they're typical, and then send them home. If we just made that one change, that would change a lot.
Okay. As a note for the technicians. Yeah, I think that's going to really deburden patients in terms of diagnostic testing. And if there was one kind of line of treatment or hope, what would you say to the idiopathic hypersomnia
No, I
community
think you
to look
guys
forward
should,
to?
everyone should be excited. There's lots of smart people working on it. And community now that didn't exist a decade ago, essentially. So
Yeah.
I think my dad would be proud of it. I'm proud of it. Proud of you guys and everyone involved, and
Yeah.
it's fun. And it's fun, right? It's not even, doesn't feel like work, right? It's you actually.
Yeah, it's meaningful. It's really meaningful.
Yeah, there's a guy here.
It's really meaningful.
I'll give you one quote. I know you're probably running out of tape. No, but there is. This actually came up when I had to eulogize my dad recently, and I brought this up in the eulogy, but it's been on my mind lately. And there's a quote by a guy. I heard it driving around on the radio. The man's name is a journalist, a war journalist. His name's Sebastian Junger, Junger, and he said humans. And so imagine where this guy's been, right? Wars around the world. And he says humans don't mind hardship. In fact, they thrive on it. What they really mind is not feeling necessary. So if you're affected, feel necessary. If you feel hopeless, you can't help. No, you can feel necessary, right? Common man can do remarkable things.
Yeah, thank you for that. I think before we started this formal conversation, you did allude to, your father passing recently and very much how his outlook on life has shaped you. So I think as a community, we're really grateful to your father as well and to you for all that you've done.
Yeah, appreciate that.
It's meaningful and it's impactful and it has longevity, and much of your work has been a legacy project, I think, even without you knowing, and we really look forward to hearing more from you, certainly at our conference coming up, and want to just take this opportunity to thank you for your time today, but also just the work over the years, just the grind, which is meaningful.
Thank you for me too, and you're welcome.